Update Series Volume 44, Lesson 30, Beyond Ureteropelvic Junction, Case-Based Tips and Tricks in Robotic Ureteral Stricture Reconstructive Surgery. Authors: Mark N. Alshak, M.D., An Nguyen, M.D., Jill C. Buckley, M.D., FACS, and Andrew J. Cohen, M.D. Introduction/Workup. Since the first robotically assisted pyeloplasties, the potential of robotic tools in aiding ureter reconstruction has grown. Classic symptoms of ureteropelvic junction obstruction are well known: pain in the upper abdomen or back, usually after drinking fluids, and urologists tackle these in a minimally invasive manner with great success. Obstructions in other ureteral locations can be challenging to diagnose and offer unique surgical challenges in treatment. Ureteral strictures may lead to obstructive symptoms and can cause deterioration of kidney function. Strictures may develop from impacted stones, as sequela from ureteroscopy, as a result of radiation, as a complication from prior surgery, or from idiopathic causes. While obstruction from extrinsic causes and stones is common, this lesson will focus on ureteral strictures that have failed endoscopic management. Patients can present acutely with upper tract obstructive symptoms, such as flank pain, nausea, and vomiting. Others can be incidentally found to have silent hydronephrosis without symptoms. A detailed history and physical are important in the workup of ureteral strictures. Patient factors, such as diabetes, habitus, prior surgical history, and history of radiation, directly impact the suitability and success rates of surgical approaches. When a stricture is suspected, workup should include renal function tests and urinalysis. Ultrasound is a good non-invasive tool to screen for hydronephrosis. If ultrasound reveals hydronephrosis or clinical suspicion continues for ureteral stricture, imaging of choice is a CT urogram to rule out stones and evaluate overall anatomy and renal parenchyma. For asymptomatic patients, a nuclear medicine scan can evaluate if hydronephrosis is clinically meaningful. It also provides split values for kidney function. Generally, reconstructive urologists would attempt ureteral reconstruction for a renal unit with greater than 20% differential function. For patients with lower function, patient-physician shared decision-making should be emphasized. Other factors, such as propensity to form kidney stones, baseline renal function, anatomy of the contralateral kidney, and other health issues, may inform this decision. The discussion of repair of ureteral stricture versus nephrectomy can be a difficult but crucial discussion for poor renal function when differential function is less than 20%. The important considerations of a ureteral stricture are both the location and length of the stricture, as they will help dictate the repair options available to the urologist. An up-and-down O-gram can help achieve this. Cystoscopy with cystogram and retrograde pyelograms may be performed combined with either CT urogram or antegrade nephrostogram in the workup of a ureteral stricture. If a Bowari flap is planned, ensuring there is adequate bladder volume is critical via cystogram or other means. Counseling patients about new-onset lower urinary symptoms from a bladder reconstruction is important, but in our experience, it is not overtly noticeable to most patients. Once a ureteral stricture is identified, referral to a high-volume reconstructive urologist should take place. If kidney function is not compromised and the patient is not too symptomatic, a patient does not require decompression with a ureteral stent or percutaneous nephrostomy tube. An important consideration is ureteral rest before repair. If a patient requires decompression, they should have at least 4 weeks of a ureteral stent-free period with no hardware or conversion to a nephrostomy tube, as repair success rates are higher with ureteral rest. General surgical approach. Historically, reconstructive ureteric surgeries would be performed open. However, in the hands of an experienced reconstructive urologist, a robotic approach can almost always be attempted. Nevertheless, it is important to counsel patients that a robotic approach may not be feasible and that conversion to open might be necessary. Even for recurrent strictures after endoscopic or prior open repair, a robotic approach by a high-volume reconstructionist can have a 90% success rate. Moreover, the robotic approach in radiation-induced ureteric strictures also has high success rates of greater than 88%. The factors that determine which repair options are feasible depend on the location and extent of the ureteral stricture. These repairs must aim to avoid further ureteric damage, preserve ureteric vascularization, achieve a tension-free anastomosis, and if possible, achieve reinforcement of the reconstruction with a flap of omentum or perinephric fat to provide an additional vascular source. Robotic systems are one of many tools used to complete a safe and successful surgery. To that end, the techniques described herein can be applied via multi-arm robotic systems or even laparoscopically for those with ample experience. Growing in availability are single-port robotic systems. First used in pyeloplasty, these are increasingly used to tackle ureteric repairs in varied locations. Single-port robotic approaches may be favored in situations where there are large amounts of bowel adhesions expected, as a single insertion point requires less lysis of adhesions. The single port also allows multi-quadrant access from a single location. This can be particularly helpful, for example, in the harvest of an omental flap for use in later reconstructive efforts without patient repositioning or extra port placements. Likewise, the single port allows for alternative approaches, such as extraperitoneal, which may avoid bowel complications entirely and allow for more hidden incisions. Nonetheless, multi-arm robotics account for most ureteric robotic reconstructions and allow very challenging reoperative cases to be successfully completed. When considering robotic surgery in complex abdomens, starting with a 5 mm port for access in a virgin area to laparoscopically assess the level of adhesions is helpful before committing to a robotic approach. Given the wide array of ureteric strictures and locations, there is a wide assortment of techniques that are needed to successfully perform ureteroplasty. It is important to be prepared with preoperative imaging, but also to expect that intraoperative findings may not recapitulate imaging. During preoperative counseling of a patient, the clinician needs to emphasize that the final plan is only known with 100% certainty at the time of the operation with visual inspection of the ureter itself. The entire reconstructive ladder should be discussed with the patient due to variability with intraoperative findings. Factors such as stricture length, location, tissue quality, fibrosis, tissue compliance, available blood supply, adjacent adhesions, and available flaps or grafts may dictate the steps taken during the operation. As such, we present a series of complex cases to provide an understanding regarding these techniques and how plans may change. Case presentations. Case 1. Augmented roof buccal graft. A 69-year-old female with a history of perforated colon and Hartmann's procedure presented with percutaneous nephrostomy tube in place. She had new-onset left hydronephrosis and a ureteral defect suspected postoperatively. Left retrograde showed a mid-ureteric 2-centimeter defect. In planning this surgery, options include ureteral reimplantation, ureterostomy, or buccal graft ureteroplasty. The perforated colon may make the dissection to find the ureter challenging. Depending on comfort, it may be useful to inform a colorectal surgeon to be available for colonic reflection. Our approach to aid in ureteric dissection was to perform intraoperative ureteroscopy. The ureter had a clear area of stricture notable with mucosal irregularity and friability. The scope or wire could not be passed proximal to this area. We left the scope indwelling for later assistance in the case and to complete the ureteroscopy into the renal pelvis once the stricture was transected. The findings suggested that the stricture had an obliterative segment. In such cases, tension can be taken off the repair via an augmented roof repair. This may be useful when full mobilization of the ureter is difficult given prior surgery or radiation. Robotic ports were placed in a virgin area away from her prior incisions and stoma. Visualizing the ureter was difficult given that the retroperitoneum had changes associated with prior abscess and urinoma. It can be helpful to use indocyanine green to help visualize difficult ureter anatomy. Indocyanine green was administered into the percutaneous nephrostomy tube, and Firefly was used to visualize the ureter. IV indocyanine green is used to subjectively evaluate a flap or tissue, such as the appendix, Boari, or tip of ureter. This ensures that there is adequate blood flow to the margins of the repair. Gray areas were seen and indicated poorly perfused tissues that likely needed to be removed. We used intraureter indocyanine green via a percutaneous nephrostomy tube to help find the ureter itself as the ureter then fluoresces. Once the lumen is cut open, any intraureter indocyanine green would spill, limiting the utility of IV indocyanine green to evaluate for blood flow as tissues will already be stained green. The ureter was transected at the site of obstruction. About 1 centimeter of ureter was taken out of continuity for this, but inspection revealed the neighboring ureter to be narrow and irregular. Moreover, given prior surgery, mobilization of the ureter was not fruitful for providing a tension-free ureterostomy repair. Hence, the surrounding 4 centimeters of ureter was spatulated and prepared to accept a graft. In this way, we planned an augmented roof buccal graft ureteroplasty. A buccal mucosal graft was then harvested. Our standard method is as follows. The Stenson duct was identified and marked. We then proceeded to harvest our graft, starting our dissection approximately 2 millimeters from the vermilion line of the lip and extending back to harvest a 1 centimeter wide by 4 centimeters long graft. This was defatted on the back table. The mouth was closed with an interrupted 4-0 chromic stitch, although some surgeons do not close this wound. The posterior wall of the ureter was reconstructed, creating a wide ureteral plate. The graft was then fashioned into an ellipse and sutured into position in a mucosa-to-mucosa fashion. A graft bed of omentum was fashioned. This was brought up and around the area of repair. Quilting stitches were used to directly fix the graft to its bed. It is imperative that a healthy graft bed is provided and is in direct contact with the graft. A stent was secured across our anastomosis. Using pressurized fluid via the percutaneous nephrostomy tube, we tested for adequate closure. A Foley catheter, drain, and percutaneous nephrostomy tube were left in place. The drain and percutaneous nephrostomy tube were removed postoperative day 1, and the ureteral stent was removed on 6 weeks postoperatively. She has done well, with no recurrence of hydronephrosis on follow-up imaging. Case 2. Ureterostomy. A 73-year-old male with a history of nephrolithiasis and multiple ureteroscopic interventions presented after recent percutaneous nephrolithotomy. He was found to have a relatively short 1 centimeter stricture located 2 to 3 centimeters distal to the ureteropelvic junction on antegrade nephrostogram and retrograde pyelogram. Given the length and location of the stricture, the patient was counseled on possible ureterostomy with primary repair with or without nephropexy or buccal mucosal graft augmented repair. In the case of a non-obliterated ureteral stricture, buccal mucosal graft may be used, especially if there is concern for inadequate length after excision for primary anastomosis. In the case of an obliterated stricture, where there is no pre-existing lumen to augment, a nephropexy may be performed to improve mobility of the proximal aspect of the repair, allowing avoidance of graft. The patient was positioned in flank position with access to his nephrostomy tube and urethra. It is very helpful to have access to pre-existing antegrade access during surgery. There was significant retroperitoneal fibrosis from his extensive stone treatment history. Antegrade diagnostic ureteroscopy was performed to confirm the stricture location, which was just distal to the ureteropelvic junction. We then marked this location and performed retrograde ureteroscopy to confirm the length of the scar, which was 1 centimeter. Use of tile pro and firefly fluorescence was key in coordinating the efforts of the surgeon at the console and the surgeon operating the ureteroscope in accurately identifying and confirming the length and location of the stricture. After confirmation that the scar was obliterated but relatively short, primary repair with ureterostomy was chosen. Excision of the scar tissue was performed, and we then proceeded with spatulation of the ureter on each side. Mobilizing the renal pelvis and distal ureter was key in maintaining a tension-free anastomosis. We confirmed with IV indocyanine green that each side of the anastomosis was well vascularized. A 10 French red rubber catheter was used to calibrate the ureter and confirm adequate spatulation and scar excision. Anchoring interrupted sutures with 4-0 Vicryl were used to line up the ureters. We then proceeded with running 4-0 Vicryl to complete the anastomosis. A 6x24 double J stent was placed prior to completion of the anastomosis. The nephrostomy tube was removed. A Foley catheter was left for 5 days, and the ureteral stent was left for 4 weeks. Follow-up renal ultrasounds at 3 and 12 months monitored for resolution of hydronephrosis. Hydronephrosis can persist after surgery, but should be the same or better with an absence of physiological and clinical symptoms. Case 3. Revision Ureteropelvic Junction. A 27-year-old female with left ureteropelvic junction repair as a child presented with intermittent flank pain with hydration and certain positions, as well as recurrent UTI. A CT scan was done, which showed recurrent ureteropelvic junction obstruction. Her renal scan did not demonstrate obstruction, with half-life of radionuclide in kidney of 9 minutes, but given the patient's persistent symptoms, a diagnostic ureteroscopy was performed, which revealed a 1 centimeter narrowing of the ureteropelvic junction. The patient was counseled regarding options for robotic pyeloplasty revision. In the case of a non-obliterated ureteral stricture, buccal mucosal graft may be used, especially if there is concern for inadequate length after dismembered pyeloplasty with removal of ureteric segment. In the case of an obliterated stricture, where there is no pre-existing lumen to augment, a nephropexy may be performed to improve mobility of the proximal aspect of the repair. If there is an adequately capacious renal pelvis, a U-shaped renal pelvis flap can be raised to do an augmented anastomosis with or without a buccal mucosal graft. The ureteroscope identified the area of prior reconstruction, which appeared narrow and 1 centimeter in length. The scar was then excised after the renal pelvis was adequately mobilized to perform a primary anastomosis without complex maneuvers. The renal pelvis was then anastomosed, starting with anchoring interrupted sutures. Anchoring sutures, often held by the 4th robotic arm, can line up the ureter to the pelvis and enable ease of suturing. Another technique that can be helpful is using a hitch stitch. In this technique, a barbed suture temporarily lifts the renal pelvis or other suitable structure as a form of hands-free traction. We proceeded with running 4-0 Vicryl to complete the anastomosis. A 6x24 double J stent was placed prior to completion of the anastomosis. In this case, a Foley catheter was left for 3 to 5 days, and the ureteral stent was left for 4 weeks. We typically do follow-up renal ultrasounds at 3 and 12 months to monitor for resolution of hydronephrosis. Case 4. Bowari flap and bladder hitch. A 77-year-old male with metastatic penile cancer underwent robotic pelvic lymph node dissection. He had an unrecognized left ureteral injury complicated by urine leak. Ultimately, after surgical drainage and time, an 8-centimeter segment of strictured ureter was confirmed. He had a cystogram determining at least 350 milliliter bladder capacity. The patient was planned for a Bowari flap. An ileal ureter interposition could be performed if the bladder was inadequate in size to bridge the injury, or if the injury was deemed to be longer than previously noted. If using an ileal ureter, it is important to counsel the patient regarding mucus in urine and potential implications with absorption and renal function. Due to significant scarring from his urine leak and infection, antegrade ureteroscopy was needed to identify the proximal ureter. By activating the ureteroscope light, the ureter can be seen via firefly imaging. This can help guide the dissection that would otherwise be very challenging given prior urinoma, infection, scar tissue, or abnormal anatomy. The bladder was released from the anterior abdominal wall, and a wide-based U-shaped flap was marked. A wide-based flap is critical to maintain blood supply to the tip of the flap. The bladder was hitched to the ipsilateral psoas tendon to reduce tension on the flap. The flap was raised, and a new ureteral orifice was made. The ureter was sewn to the new orifice, and the ureteral stent was placed. The bladder flap was tubularized, and the cystotomy was closed. A Foley catheter was left in place. The Foley was removed 2 weeks later after a negative cystogram. The ureteral stent was removed at 4 weeks, and the nephrostomy tube was removed at 5 weeks after a capping trial and antegrade pyelogram. Postoperatively, he did well, with resolution of his symptoms at the 2-month follow-up. Case 5. Ureteral reimplant with psoas hitch. A 66-year-old female with a history of hysterectomy suffered a left ureteral injury identified intraoperatively. After an attempt at retrograde stent failed, a percutaneous nephrostomy tube was placed. 6 weeks later, after she recovered from her surgery, an up-and-down ogram was performed, showing a 2-centimeter defect in the distal ureter. Retrograde ureteroscopy and antegrade ureteroscopy were performed and showed complete occlusion. Given the distal nature of her stricture, a robotic ureteral reimplantation was planned. Given how distal and short the stricture was, we felt that a transecting anastomosis would be safest and best using a healthy portion of ureter. The ureter was transected and spatulated. A non-transecting ureteric repair may be favored in cases of radiation, where a full transection of the ureter may lead to a decrease in already compromised vascularity. In non-transecting repairs, a long spatulation is made in the ureter, and a side-to-side anastomosis to the bladder can be performed. In this fashion, the bladder is brought to the ureter, which remains in situ. In this case, an anastomosis of the ureter to bladder with 4O Vicryl was performed, visualizing mucosa to mucosa apposition. Just before closing this anastomosis, a 6x24 stent was placed. Often, the placement of the ureteral stent during repair can be challenging. Sometimes the ureter is accommodating and at an angle where a stent can easily be passed without difficulty. Other times, various maneuvers are necessary to aid in stent placement. An angiocath can be used and pointed toward the ureter, passing the wire and stent retrograde. Another way is to use the metal portion of the suction irrigator and introduce a wire into the ureter. Along the same lines, sometimes a counsel tip catheter can be placed and positioned through a cystotomy to introduce a wire into the ureter, and a stent can then be placed. The percutaneous nephrostomy tube was then removed while holding the stent in proper position across the anastomosis. Occasionally, the percutaneous nephrostomy tube removal can dislodge the stent, so a chromic stitch to hold the stent into position or using the robotic arm to hold the stent directly can prevent this. We then completed the closure in a tension-free fashion. We tested the integrity by filling the bladder via catheter with 300 milliliters of saline. No leak was seen. To take further tension off the repair, 4O Vicryl was used to hitch the bladder to the psoas tendon, throwing stitches parallel with the tendon. A 19 French drain was left indwelling via the assistant port. On postoperative day 1, the Foley catheter and abdominal drain were removed. She had her stent removed 6 weeks later without issue. Follow-up at 3 and 12 months with ultrasound revealed resolution of hydronephrosis. Case 6. Appendiceal flap. A 52-year-old female patient with a history of recurrent nephrolithiasis presented to the clinic with a percutaneous nephrostomy tube. She had a ureteroscopy for an obstructive 5 mm ureteropelvic junction stone. She developed flank pain 6 months later and was found to have severe right-sided hydronephrosis. She had a percutaneous nephrostomy tube placed. Initially on referral, the patient presented for a second opinion for a diagnosis of ureteropelvic junction obstruction and plan for a dismembered pyeloplasty. After history and a physical, we sought further ureter staging. On retrograde ureteroscopy, a mid-ureter stricture just proximal to the iliac crest was noted without passage of contrast. Likewise, antegrade ureteroscopy revealed stricture that started approximately 3 centimeters below the ureteropelvic junction. This type of discrepancy highlights that confirmation of disease with up-to-date staging is imperative to ensure that the correct clinical situation is known prior to surgery. Given the length and location of her stricture, possible repairs included downward nephropexy with ureterosterostomy, ureter repair with buccal graft, spiral flap, or use of the appendix. Diagnostic ureteroscopy was performed, and the scope was parked at the stricture location. The strictured segment appeared longer than previously identified. A downward nephropexy would not be sufficient. Her renal pelvis was not large enough for a flap, but she did have a healthy-appearing appendix. Given use of the appendix as an interposed layer creates 2 suture lines, it is generally preferable to use the appendix as a vascularized onlay flap, detubularized, versus as an interposition flap, tubular shape, when possible. The appendix was taken via gastrointestinal anastomosis stapler with preservation of the mesentery. To ensure that the appendix is patent and to aid in getting traction to open the appendix, placing a 5 French open-ended ureteral catheter can be useful. Using the 5 French open-ended ureteral catheter for tension, the appendix was opened at the antimesenteric border and irrigated. The appendix was positioned such that twisting of mesentery was prevented. A running anastomosis was performed with 4O Vicryl on the medial border of the ureter mucosa to mucosa on the open appendix, and then closed laterally with good lie of the appendix without tension. A 6 by 26 centimeter ureteral stent was placed. Omentum, previously harvested, was used as a flap to cover the repair. At times, an interposition may be necessary. Percutaneous nephrostomy tube remained in place, and a 19 French Blake drain was placed. Postoperative drain creatinine was negative, and an antegrade nephrostogram showed good flow down the ureter. Abdominal drain and percutaneous nephrostomy tube were removed prior to discharge. Ureteral stent was removed 6 weeks postoperatively, and the patient has no evidence of stricture recurrence at 12 months. Case 7. Enteric ureter reimplant into ileal conduit. A 71-year-old male patient with a history of muscle-invasive bladder cancer underwent radical cystectomy with ileal conduit creation. 3 months after his initial surgery, he was admitted with urosepsis and found to have a high-grade left ureteroenteric stricture, and a nephroureteral stent was placed. After nephroureteral stent placement, the patient improved and creatinine normalized. 2 years later, he expressed desire to become tube-free. After discussing ureteral rest, he was converted to percutaneous nephrostomy tube and underwent restaging imaging a few weeks later. A Foley catheter with 5 cc in the balloon was placed into the conduit. We insufflated to 15 millimeters of mercury of pressure using a Varese needle subcostally, and then placed our first 5 millimeter port under direct vision with the lap camera in the upper left quadrant, away from prior scars and the conduit. Using laparoscopic clearance of adhesions, we were able to place additional ports. The left hydronephrotic ureter was identified. Given the appearance, a non-transecting reimplantation was chosen. In cases of prior cystectomy, prior ureteric dissection may render a repeat ureteralysis extremely challenging, and it is often more straightforward to bring redundant conduit or neobladder toward the ureter rather than vice versa. We identified the probable entry of the right ureter, which remained unaffected by our dissection. We created a long cut through the thickened left ureter until the lumen was directly seen. We widely spatulated the ureter both distally and proximally up into the conduit as well. Tissue edges were bleeding and healthy. An anastomosis on each side of the ureter with 4O vicryl was performed, visualizing mucosa to mucosa apposition. Prior to finishing the closure, a Bander stent was placed with the distal end coming out of the conduit stoma. The left percutaneous nephrostomy tube was removed. Omentum was used to provide support to the repair. A 19 French drain was left indwelling via the left assistant port. On postoperative day 1, drain creatinine remained negative and the drain was removed. Ureteral stent was removed 6 weeks later. At ultrasound follow-up at 3 and 12 months, hydronephrosis remained resolved. Did you know? In the hands of an experienced reconstructive urologist, robotic approaches for ureteral strictures have success in upward of 90% of patients. Preoperative workup with both retrograde and antegrade imaging, with confirmatory ureteroscopy if necessary, to fully understand the extent and location of the stricture is imperative, as it will dictate which repair is most appropriate. A ureteral stent-free period of 4 to 6 weeks before attempting repair improves outcomes. Flexibility in approaches and the ability to pivot intraoperatively are necessary to successfully reconstruct ureteric defects. For more information or to claim CME, please visit the AUA University at auanet.org/university.